Thank you. It's a privilege to be here and to be last. So what I will be presenting on is the ACA and health insurance challenges faced by AYAs. I want to acknowledge my collaborators. It takes a village to do this work. The data that I'm going to be presenting is based on a collaboration with the Childhood Cancer Survivors study. And I want to acknowledge Livestrong and NCI's funders. So the Childhood Cancer Survivor study, which many of you have heard about, over the past 2 days was funded in 1994. It's a retrospective cohort. It's 26 contributing centers. All the centers except for Canada and the Toronto site participated in this health insurance trial, since Canada has a different healthcare insurance system. And the individuals who participate in the CCSS are ones who are diagnosed up to age 21, so it includes adolescents and young adults. And I'll talk about that a little more later. So in the Childhood Cancer Survivors study, young adults are included in this group. Childhood survivors are at risk for being uninsured, was data that I presented in 2005 in JCO. Compared to sibling controls, survivors looked like they were less likely to have insurance. So statistically significant. However, what was more important was that it really looked like, when we dug into questions about the quality of their insurance, that was where the disparities may be, and it inspired us to do this next trial. We know that quality of health insurance is critical for survivors, and that uninsured childhood survivors, as Jackie's work has shown, are at risk for not receiving recommended survivorship care. So one of the things that I'm going to talk about as well is specifically young adults. So in the work that I'm going to be showing you, we actually oversampled so that we would find more of the issues related to young adult cancer survivors. And in the sample that I'll be presenting, we have about 100 of those represented. I wanted to make a plug because we collected the data last year, and if people are interested in doing AYA-specific research within the data set, I'd be happy to speak to anyone. Young adults are at risk for being uninsured. We've heard this now as the theme of the conference. Up to 1/3 of individuals aged 19 to 29 did not have coverage, and that's why we really wanted to do this in doing this work, to oversample those individuals. Half of those are 133% under the federal poverty level, and I'll get to that later about the Affordable Care Act and the implications of that. So that means, translated, that half of them earn as individuals less than $11,170, and for a family of 4 under $23,000. The good news is, since the Affordable Care Act was rolled out, there's been a decrease of a couple of percentages of young adults who are uninsured. So some of the provisions targeting increasing access to health insurance are clearly starting to work. But in 2009 as well, almost half of young adults reported foregoing medical care because of cost. So even individuals who have insurance are foregoing cost, as well as those who do not have insurance. So the Affordable Care Act was established to improve access to affordable health care and have provisions that prohibit preventive care co-pays, that promote primary care, and ban pre-existing conditions and exclusions. We've heard about this a lot in the past 2 days. What we've also heard about since the Affordable Care Act was rolled out was a lot of efforts to block it, to pull it back. I feel like this has been a bit of a soap opera. We had this grant, the Affordable Care Act was passed, and we started looking at changing questions, and there was a question of whether it would be repealed. Just as recently as a week or two ago, some provisions were held back to have companies who have greater than 50 employees mandate required insurance. So it really is an interesting, fascinating, moving target, exciting, but also can be difficult and challenging. So the coverage preferences and familiarity, though, with this Affordable Care Act are unknown, particularly in the survivor population. The data that I'm going to present is what we know from the Childhood Cancer Survivors study. Within the AYA population, I don't know that there's been work specifically about precedence and familiarity with the ACA. So Dr. Blyer, I want to say, if anyone wants to look at an article, he did a wonderful perspective in this 2010 Cancer Journal article, kind of looking at the potential benefits of the Affordable Care Act for AYAs, but also poking some holes in a lot of the potential difficulties with it. And so that's, I think, very important to keep in mind. This was an article that was done by Wolfson, though, in 2010. where she talked about potentially favorable outcomes for young cancer survivors, how the Affordable Care Act prohibits coverage denial due to pre-existing conditions. As the Affordable Care Act is rolled out between 2010 to 2014, protections are based for adults and for children who've had a pre-existing condition. It allows children to stay on their parents' policy until age 26. It expands the Medicaid eligibility to people who are up to 133% at the federal poverty level. That is particularly important in our findings in the JCO paper in 2005, and consistently we found that childhood and AY cancer survivors are disproportionately likely to be covered by Medicaid, and so to expand this Medicaid access is very important to this population, requires coverage for recommended preventive care, promotes primary care through patient-centered medical homes, which facilitates coordinated care between primary care physicians and other patients' providers, which will be critical for these AYA patients and survivors. Establishment of temporary high-risk pools to help individuals be able to establish affordable insurance, and prevents group health plans from imposing lifetime limits, particularly based on people with medical difficulties are protected from really having a cap on their elevated medical costs. In addition, there are some other provisions that I think they're very helpful. Melissa just spoke about, which I think is also a very important part of the Affordable Care Act, are requirements for insurance companies to cover costs related to clinical trials. So that's also something that's very important for these AYAs in moving forward. So the design that I'm going to present is a two-phase study. The first phase is a qualitative exploration, and the second phase is a survey comparing childhood survivors and their sibling controls from the CCSS. To develop our survey, we drew from the many different national surveys to inform our questions, and then piloted the survey, piloted the qualitative interview guides to develop our own tools. So the first phase of the study, we wanted to explore childhood survivors and siblings' perceived quality coverage, their needs and difficulties, and their knowledge about existing health insurance-related legislation. So the other thing, so when we, that is what we proposed to do. In the meantime, when the study started rolling out, the Affordable Care Act was being debated. We also wanted to check, though, when we had proposed the study, and in comparison to the Affordable Care Act, knowledge of things like the Americans with Disabilities Act, with the HIPAA provisions for patients for individuals to stay on their insurance for a year if they've had coverage, not to lose that coverage. The Family Medical Leave Act, which protects individuals from losing jobs based on needing to leave due to medical related issues, and COBRA. So we really not only wanted to see, as we marched out, survivors' impressions of the Affordable Care Act, but how that compared to other health insurance legislation that had been longstanding to protect them. And what we found was actually very disappointing. So the phase 1 data collection and analysis, as I had mentioned, we oversampled individuals who were younger, who were under 30 years, and we also oversampled individuals. We stratified our sampling within the CCSS based on insurance status because we really wanted to talk to those individuals who were uninsured. We developed a semi-structured interview guide. We collected the data between 2009 and 2010. We recorded the interviews, conducted thematic content analysis, analyzed it in vivo, and we got their socio-demographic and medical data from the 2007 last CCSS survey that had been administered, and updated information that might have changed, like marital status. So the sample was, so we succeeded in getting over half of the participants were under 30 years of age, about half were female, 74% were white, non-Hispanic, half of them had just less than a college education. We had 40% of them with a household income of under 20,000. That's actually lower than the overall CCSS sample, but we had oversampled those who were uninsured, and about half of them were single, and 18% had had a second malignancy or recurrence. We ended up surveying 39 participants, and what we found was, first we looked at the uninsured survivors and what they thought about their current coverage. And there was actually little concern expressed about their lack of coverage. The nice thing about qualitative research is you can get a sense of the impressions, not just what people answer in terms of questions, but what might underlie it. There really wasn't a tone of concern. They seemed to cope by avoiding or minimizing their need for care. This was an example quote. I just don't think about it. It's just not something that I try to worry about. Some had concerns about future health, though. The concerns about future kept popping up in kind of side comments. Everything was okay now, but then later on, there was this anticipation that the shoe was eventually going to drop and that they would eventually have to cope with it. Yes, it does concern me that, if something happens, nobody's going to give me insurance. That's a pre-existing condition and $1 million worth of bills. So it's on their minds, but they're kind of avoiding it. Insured survivors' satisfaction with current coverage. Overall, when you ask them about their satisfaction with services, they seem to be very satisfied. Say things like, I'm glad I have insurance. But when you dig in, there really seems to be a bar of low expectations that were set. There seemed to be a theme of reluctance to complain or seem ungrateful. It could be better. It gets more expensive every year and has less coverage. This was someone who had said that they were satisfied with their insurance. What was also really profound about this, albeit small qualitative sample, is that over half had reported an annual out-of-pocket cost of over $22,000. And so they said, although they said that they were satisfied with their insurance, they were admittedly dissatisfied about cost. And the reason why that $2,000 marker is really important is that's a point, an indication of underinsurance, of being underinsured. And so among these individuals who are underinsured, they were still, when you ask them about their satisfaction with their insurance, they still express satisfaction, even though the costs did seem very crippling in some cases. We have a huge deductible because we're paying, like $1,000 a month, but that's all we can do. We both have pre-existing conditions. Insured survivors clearly had difficulties obtaining and using coverage. What we had found in our original survey in 2005 is that 1/3 of cancer survivors, compared to 3% of their sibling controls, had difficulty obtaining coverage. So here we heard some of those experiences. They were very frustrated by the process of receiving coverage. I was so flabbergasted when I went to try to get insurance on my own. I thought it would be a simple, easy experience, but I was severely wrong. And then a lot of profound difficulties of those who had it, of really being able to use it. I don't even know what's covered because I tried reading the booklet, and of course I don't understand all the language in it. This is a survivor when they're being asked is admitting it, but I don't know how many of those would actually admit that during the process of their treatment, of their follow-up visits or to providers. When we asked about preferences, they prioritized the need for coverage for routine care services and physician choice. And half of them emphasized the importance of having no exclusions or denials due to pre-existing conditions. I don't think survivors should be discriminated against for pre-existing conditions. I think it's important that they receive follow-up. So in terms of the Affordable Care Act, if we look at the priority in terms of having continuity care, primary care physicians, and then no exclusions or pre-existing conditions, we are right on track with these survivors' needs. When we asked them about their future coverage, there was definitely a salient worry that costs would eventually increase or they would lose coverage. Next year, I have had so many hours to have insurance, and I may not have enough hours, that are worked. So that's what I'm concerned about. Worried the costs would become burdensome, and many uninsured and insured survivors feared future coverage problems, talking about that inevitable catastrophe that was going to hit. When we asked about knowledge of health insurance-related legislation and resources, we went over, at that time, we went over the ADA, the FMLA, COBRA, and HIPAA, and there was just a pretty salient lack of knowledge. Interestingly, these interviews were being conducted during the time that the Affordable Care Act was being proposed and debated, and only one of the 39 participants actually mentioned it. Almost all participants expressed, though, an interest. We asked them about whether they would be willing to participate in an educational program to learn about their health insurance coverage and rights. So that was promising. And then we have some quantitative data on that. So lack of knowledge, but high interest. So to summarize the first findings, uninsured survivors seem to minimize their need for care. So many insured survivors had difficulty obtaining and using their coverage, so those who had care not necessarily used it. Insured survivors had low coverage expectations, particularly ability to express their interest and satisfaction with having their coverage, but some admitted room for discussion and discontent around their costs. There was a salient fear of a health catastrophe and potentially losing coverage later on, and a lack of knowledge about insurance-related rights and protections. So that was the qualitative. Then we went into the phase 2 study. So the objectives here were to examine impressions of current coverage. So we used the phase 1 findings to inform some of the survey questions. We looked at priorities for health insurance coverage, familiarity with the ACA and the other health protections that I mentioned, and impressions about the ACA. The survey content, we looked at coverage and coverage history, employment, healthcare utilization, coverage quality, and healthcare reform and the legislation. In terms of the data collection, we did a random sampling, again, oversampling individuals who are under 30 to get a significant sample enough of young adults who were in the data set. What I'm going to present are results that are unweighted, but we are going to weight these results up to match the population in the overall CCSS study so that our findings can be in sync with the other participants for whom a plethora of data have been found over the past decades with the CCSS. One thing I want to say is, though, prior to this presentation, I did look at differences separating out for our own edification of individuals in this data set who fit the AYA cancer patient criteria. So we did a stratified analysis of these findings of individuals who are 15 and older versus under 15. And what I found sociodemographically is that they differed in terms of the AYA patients were more likely to be married, more likely to have insurance coverage by their spouse, and more likely to be covered by employee-sponsored insurance. But when I looked at the stratification in terms of the findings, AYA patients versus other younger patients in the sample, I didn't see a difference. So I'm going to be presenting the findings, not stratifying out AYA patients in particular, but just looking at survivors who were diagnosed prior to 21. We looked at uninsured and insured survey versions. We looked at, we completed the data collection versus mailed and internet completion. The final sample, we had almost 700 survivors and 211 siblings. We had a respectable response rate, a 64% response rate of survivors with a 70% participation rate, and siblings, the response rate was 59%, and the participation rate was 65%. So this is what the cover letter looked like. We had an insured survey. An uninsured survey, we asked them a question. Basically, do you currently have health insurance that covers hospital and doctor care? And based on how they answered that question, they were directed to the survey that color-coded matching their answer. So the insured survey was green, the uninsured was yellow. So this is what just an example of one of the item sets looked like. We asked them, think about your ideal health insurance plan. Please rate how important each of the following health insurance features are for you. And they selected options of very important to not at all important. And I'm going to talk about some of these findings in relation to the ACA. So this is the sample. We had no difference in terms of the age of the survey. We had about a third were age 22 to 29, a third were 30 to 39, a third were 40 to on upwards to 62. Almost half of the survivor sample were male. We had not a lot of a very homogeneous sample in terms of race and ethnicity. About 93% of the sample was white. In terms of education, we had some variability there, but 56% of the sample had completed college and above of the survivors. When we looked in terms of marital status, we kind of saw what we expected from past work with survivors, that the survivors were less likely to be married compared to their siblings. And when we looked at employment rates, we saw about 3/4 of survivors and siblings were employed. So the only significant difference in terms of sociographic comparisons between survivors and siblings was the marital status. When we looked at cancer diagnosis, a third of the sample had been diagnosed with leukemia. About a third had other diagnoses other than Hodgkin lymphoma and CNS. The age of diagnosis, half of them had been diagnosed between ages 0 and 4. These were longer-term survivors. Years since diagnosis, over half the sample had been diagnosed between 22 and 29 years old, and over 20% over 35 years ago. 84% of them had had no second cancer recurrence, but we did see that 11.5% had a recurrence and 3.3% had a second cancer. So when we look at health insurance characteristics, what we see, which is actually non-significant, is that the coverage rates are very similar to the paper we published in 2005, but because this is a smaller data set and there's a little bit of movement on the survivors coverage, there's now a non-significant effect of insurance coverage when you compare survivors and siblings. What I want to say about this, so in the 2005 survey, 88% of survivors were insured compared to 91% of siblings. What I want to say is this is a higher coverage rate than we see in the general population. In the general population, we are looking at more of a 15% uninsurance rate, the general population as a whole. But as like Karen Emmons had said earlier today, the fact that that greater than 11% of survivors don't have coverage is still problematic. These are individuals who really need coverage, so even though they look favorable for just looking at numbers in terms of percentage of coverage, it's still a huge problem to address. I kind of had a horrific moment when I had presented some of the earlier data on insurance coverage to some health policy colleagues who thought that that 88% coverage was very high and not potentially a significant problem looking at insurance coverage of survivors. When we looked at policy owners, we're not seeing a significant difference between survivors and siblings. We're seeing that 71% versus almost 69% of participants were covered by their own policy. When we look at insurance type, the majority of survivors and siblings are covered by employer-sponsored or military insurance, but siblings appear to be significantly more likely to be covered by this mechanism. So with 83.9% versus 74.8% coverage through employer-sponsored military insurance. And then what we see, similar to previous findings, is that survivors are more likely to be covered by Medicaid or state insurance compared to siblings. When we looked at insurance ratings, though, similar to our qualitative results, they seem overall fairly satisfied, and there was no significant differences between survivors and siblings. Over 50% of each of the survivors and siblings rated their health insurance as very good or excellent. When we drill down to characteristics, we had asked survivors what was the kind of most they'd be willing to pay out of pocket for health insurance. And survivors and siblings similarly rated the average amounts they would be willing to pay. We asked them per month for individual and per month for family. What's I think salient about this is that if you multiply the survivor's threshold of what they're willing to pay per month by 12, it exceeds that $2,000 a year out-of-pocket expenses, which is what we consider, again, a marker for underinsurance. So although there's no differences in terms of tolerance for siblings and survivors in terms of how much they have to pay at out-of-pocket costs, I think it's very important to look at what level they're willing and how important it is for them to have this insurance coverage. When we asked about denial of different types of coverage, we see significant differences between survivors and siblings, but the denial rates overall, admitted denial rates, were low. 14% of survivors, 14.7% of survivors had ever been denied health insurance, 3% dental, 2% vision, and that's much higher than the siblings. And when we asked them about difficulty obtaining coverage just in the past 2 years, we had 6.7% of survivors saying that they'd had difficulty in the past 2 years. So again, indications they get insurance, are able to get it, they have difficulties, and the question still remains, well, what kind of insurance are they able to get? We asked them about the importance of plan coverage features and costs, and these are some selected characteristics. What we see overall is that survivors and siblings similarly rate the importance of different features, but more survivors rate them as important. So we asked them about plan coverage, plan features, and cost. And plan coverage, survivors thought what was most important was to have primary care plan coverage. They also, 2/3 of them thought dental care was important, which is very important given some of their treatments, and fairly high rates of coverage for importance for vision care. Plan features, they prioritized not having a waiting period, being able to choose who their PCP was, and being able to self-refer. And then when we looked at plan cost, they really, survivors prioritized having affordable premiums, with 88% of survivors wanting affordable premiums. They did not want any added expense due to a pre-existing condition, and they prioritized low deductibles. When we asked them about their concerns and hopes about the Affordable Care Act, what we found was that many of them responded, don't know. Many survivors and siblings responded, don't know. So we asked them, are you hopeful about the Affordable Care Act? And what we saw is this side, I'm sorry, oops. This side is hopeful. This side is concerned, is that only about 20% of survivors, and this is not a significant difference, versus about 26% of siblings said that they were hopeful about the Affordable Care Act. However, about 50% of each didn't know whether to be hopeful. And we see the same thing, the same pattern here. Only about less than 20% of survivors were concerned about the Affordable Care Act versus 20% of siblings. But when we ask them, they don't know, greater than 50% of survivors that they didn't know whether to be concerned. We asked them qualitatively to fill in their concerns and hopes about the Affordable Care Act. And so this is a chart summarizing their themes. And what was interesting is the things that they're hopeful about are the same things that they're concerned about. And this is survivor and sibling data together. They're concerned and hopeful about the costs, about the coverage itself, about the access, the quality, and government involvement. The only thing that they were concerned about that they weren't hopeful about was the impact of the employer and potentially negative implications about the employer's ability to provide insurance. We asked about familiarity with health insurance related legislation, and what we found is, this is the slide that I think is, to us, kind of made us step back and say, whoa, is that, so these data were collected between 2011 and 2012, remember, that only about 25% of survivors and siblings acknowledge that they were familiar with the Affordable Care Act, just familiar with it. When you look at the ADA, which was passed in 1990, you get about 1/3 of each. And again, I'm focusing on the numbers across survivors and siblings because I think in some ways siblings are definitely more aware of health insurance and health-related issues by the experience of having a sibling who has cancer. So I don't think that the fact that the two bars are so close is important. I think what's important is that there's such a lack of knowledge. The Family Medical Leave Act was one that likely there's been some access and exposure to. Almost 50% were familiar with it. COBRA, what we have is about 40%, and HIPAA around the same. However, what we did was we split this up by uninsured versus insured just to look at. And where we did see the disparity was that individuals who are uninsured were across the board less likely to be familiar with all of these insurance-related legislations. These are all significant differences. These are insured survivors versus uninsured survivors, and those rates among the uninsured are disturbing. So when we're looking at coverage conclusions, survivors are less likely to be covered by employer-sponsored insurance. Survivors are more likely to admittedly have difficulties obtaining coverage. Survivors and siblings rated their coverage similarly in terms of satisfaction, and they similarly ranked the importance of plan coverage features and cost factors, but survivors were more likely to endorse these all as important. When we look at implications for the Affordable Care Act, about over half of survivors didn't know whether to even feel concerned or hopeful about it. Survivors and siblings demonstrate a lack of familiarity with the ACA and other health-related legislation. Their coverage preferences, though, the promising thing is match many of the ACA provisions. And the education and assistance of how the Affordable Care Act is personally relevant to them, though, is likely to be needed. So we have these provisions that were set up, targeted in terms of coverage until age 26 in terms of no discrimination for pre-existing conditions, high-risk state pools being set up to help people get affordable care access. And the indications are likely that they won't use them unless we help them. And I think that came out qualitatively when we talked about access, is that a lot of the insured survivors didn't really understand or were frustrated by being able to use their coverage. Overall conclusions is that there are limitations about the limitations of the ACA provisions and anticipated barriers to the uptake of some of the provisions for survivors. They're going to need both advocacy and education to help them utilize these healthcare reform benefits. This is a slide that I am presenting for Amy Davidoff, who had given it to be delivered by Kavita Patel. And so we're going to take this, I'm going to decompartmentalize it for you. So this is a study based on MEPS data. We're looking at eligibility of young adult survivors for coverage having coverage to the Affordable Care Act. These individuals, the cohort, were 18 to 39 years old, and they had been asked if they had had a cancer diagnosis ever. And in this slide was capturing the people who had said yes, they had ever had a cancer diagnosis. One disclosure that I was asked to mention is that these data are presuming that all states are participating in implementing Medicaid expansions, and so this is the best case scenario. So what we're looking at, if we're looking at the blue, are individuals who are Medicaid eligible, so individuals who make approximately $11,000. The red are people who are income eligible for exchange subsidy, so these are individuals who are making $14,000 up through about $44,000 a year, and the income above the $4,400 federal poverty level is $44,000 a year. So the Medicaid eligible participants are anyone who's making 133% up to the federal poverty level, which is at $11,000 and can go up to $14,000. The red are people 14 to 44, and the green are 44 and over. Amy, correct me if there's anything. Okay. So the question is, who would be eligible to participate in exchanges and get the premium subsidy, presuming that their employer-sponsored insurance wasn't adequate or accessible? And the good news here is if we drill down to the individuals who are currently uninsured, what we see is under these expansions, that about 90% would be getting insurance. So 50% of those who are Medicaid eligible would be getting insurance, the people who make approximately under $14,000. 36% would be income eligible to participate in state exchanges, so those individuals making about $14,000 to $44,000. And still the 12% that make over 400% over the federal poverty level limit of $44,000 still could purchase coverage. So what we're seeing is that that the Affordable Care Act would allow improvements in the uptake of coverage for these individuals. Thank you. So in closing, talking about the implications of the ACA, so it's intended to improve access and affordability through state-run high-risk pools, Medicaid expansion, and extending the age of parental coverage. Unfortunately, the reality is a lot of states had the extended age through coverage in existence already, but this Affordable Care Act could increase numbers of CCSS, but may be financially prohibitive by some. So even in the slide that we presented, some individuals who say even make 400% over the federal poverty level, $44,000 as individuals, might not really want to purchase their own insurance. And we saw, as we saw in the qualitative interviews, some of the uninsured people potentially could have afforded health insurance, they just did not want to. So there are a lot of potentially concerns that although there is coverage, this coverage might not be sought after, or perhaps might become even more financially burdensome if they actually have to purchase it. And then we'll see, we have data that I haven't presented on implications of not being able, of having financial implications of unmet medical care needs, or on the other side, paying for medical care needs and the implications on other aspects of quality of life that we'll be presenting at a later date. But we'll be able to really drill down and see what are the cost implications of having insurance and not having insurance for these individuals. The second implication of the ACA is that it could improve security of survivors with no denial due to pre-existing conditions, no lifetime coverage limits. So it could allay fears of future coverage needs. So as we talked about in the qualitative data, this kind of sense of waiting for the other shoe to drop, this inevitable health catastrophe, potentially if individuals focus on and take advantage of the provisions of the ACA, they could have some of those concerns allayed. The last is the ACA does have the potential to improve continuity and preventive care. So for making essential benefits for primary care practice visits, creating the patient-centered medical homes, requiring coverage for preventive services. So that's all promising. But if you drill down and look underneath it, part of the difficulties might be the disconnect between those benefits and the actual needs of survivors. And the one that came out repeatedly in the qualitative data, that's a good example of this, is that the proposed areas of preventive care are areas that are required, are areas that are recommended by the U.S. Preventive Task Force. So things like breast screening at specific ages. The problem is if you have an AYA patient who had breast cancer, say when she was 16, she might need to go for a different screening regimen than is going to be than is recommended by the U.S. Preventive Task Force at 40. She might need to start at 30, and that's not going to be covered. So when you drill down, the good news is there are wonderful provisions set to protect survivors, but you really need to understand underneath them and the limitations for survivors in terms of meeting their needs. Great to have more of a focus on prevention for survivors. It's not going to meet all their needs. And these are nuances that are complicated for us to understand and are really important, though, to be able to distill down to patients' level of understanding. So I thank you.